So I've been fortunate to be at Duke for a number of years, actually since 1978, if you can believe that. And I've really had two roles there. One was to develop pain clinical programs, and I've been involved in many other programs that focus on chronic pain. And our research to go along with that has always started when we work with a disease-related pain condition like arthritis, trying to understand how people cope and adjust to that pain, and then using that information to develop novel interventions to help them alter the ways they cope, essentially enhance the more adaptive strategies and change some of the maladaptive ones. And more recently, we focused on novel ways to deliver and disseminate these treatment protocols, use of smartphones, internet-based virtual reality approaches. I mentioned below a number of the key collaborators I've worked with at Duke over the years, and also at the University of Melbourne. And I'd like to acknowledge support from these various institutions, including the Arthritis Foundation. Next slide. So I'm going to talk about three topics today. First, provide a little bit of a conceptual background on this area, again, particularly emphasizing how patients view their pain. Then talk about some opportunities to alter how people understand and deal with their own pain, and then finish up with some of the issues for the future in this area. Next slide, please. So we think about pain during exercise as kind of a traditional perspective, and Lisa touched on this some in her presentation. Can I have next slide? So the traditional perspective, pain during exercise is seen as a sensory event, usually signaling some sort of injury, maybe a sprain or a strain or some muscle soreness in people who are unaccustomed to activity, more as an acute event. And the notion is if you treat that medically or you provide a temporary rest for the patient, the pain will go away in a relatively short period of time, so that most of us will say, yeah, pain, exercise is safe, like Alessio emphasized. Have next slide. Our understanding of pain, though, really has evolved over time, and this sort of more acute model of pain, particularly in people with pain that persists, has really evolved. And much of that evolution has come from brain imaging studies. There's also been other studies I could mention, but I want to focus really on the brain imaging and the pain neuroscience. And one of the most basic and early questions asked is, when you deliver a simple pain stimulus like a pinch or a heat stimulus, what happens in the brain? And what you see is what Lisa brought out in her presentation, actually activation of many, many different areas of the brain. And the notion now is it's not just the sensory areas of the brain that are involved in pain, but in fact, there's a distributed processing, even of simple pain stimuli, such that pain is the result of a neuromatrix, connections between multiple circuits and networks in the brain produce what we describe as pain. Could I have the next slide, please? And then, let's see, could you hit the button one more time? A more recent question that's been asked is, what happens when in the brain when pain persists? So if you have a chronic disease, what happens? And as you know, probably there are more and more connectivity studies which actually look at patterns connecting from one area of the brain to the other. And what we know is as pain persists, the links between different networks in the brain related to pain develop and they strengthen. And the signals literally go more quickly from one area of the brain to the next. And when you activate a pain stimulus, you see activity in all these different networks, the sensory network, the salience network, is this something I should really pay attention to, the stress network, emotion networks, action networks, and of course, pain modulatory networks. Next slide, please. So in one way you can say, well, this is so complex, how does this really help us? But in the other way, you can think, well, this provides some real opportunities. It provides opportunities for us to understand the patient, as well as opportunities for intervention. So one thing we know, pain occurs in thinking individuals. We're trying to make sense of what's happening and in behaving individuals. And we know when pain persists, people develop certain strategies, conscious efforts to try to master or tolerate or reduce the pain-related demands. And just to give you some examples of these efforts, Think about avoidance. It's really the workhorse coping example. So people engage in exercise, they get pain during it, and many people simply stop exercising, or they really cut back significantly on their exercise. And the immediate benefit, of course, is reduction of pain. We know the long-term outcome of avoidance of exercise entirely, of course, is increased likelihood of pain, deconditioning, and mood changes, often depression or discouragement. So could I have next slide? So when we think about drivers of avoidance, we have obviously those sensory circuits that get activated during an injury or during a painful episode, but we also get many other areas involved. Could I have the next slide, please? You're gonna have to hit it one more time. So think about that connectivity diagram I showed you. For some reason it just disappeared, but we see in somebody with arthritis that's had maybe multiple exercise programs over the years, they've had many experiences, that many of those circuits in the brain, I don't know if you hit it one more time and the brain will show up, I hope it will, but think about all the other areas that get activated when that knee pain, that flare occurs in the patient. So thought centers are firing away. The person may be thinking, you know, it always makes my pain worse. No one, particularly the therapist instructing me, understands this. It's terrible, it's going to get worse. These thoughts occur, feelings occur like anxiety and fear, appraisals that, boy, there's nothing really I can do to deal with this. And of course, all of this contributes to the activation of stress. So when you think about coping, we're really talking about a broad context of a pain experience, and coping, not just with the sensory aspects of pain, but many other aspects that co-occur and that are an integral part of the pain experience. Have the next slide. So what can we do about this? How do we help people become more aware of this pattern, help professionals become more aware of these patterns and change them? And I like to use the term behavioral experiments, that is, to foster experiential learning in people going through these experiences to help them gather a different perspective on what they're experiencing. So one approach that we use is recording, or helping people become more mindful through self-recording and thinking about and tuning into what they're thinking, feeling, doing, believing during a pain episode, during exercise or after exercise. Next slide. So for example, you might have an increased pain during or after exercise. There might be certain thoughts, certain self-statements that you're making that are connected to different feelings and behaviors. Next slide, please. So the thought might be, you know, I really can't cope. There's really nothing I can do. You know, this is I'm gonna end up in a wheelchair. And of course, the feelings that might occur if that's a thought going through your mind, you might be very fearful, irritable. Again, this fuels avoidance, quitting the whole enterprise itself. Next slide. One of the interesting things that happens with this type of behavioral experiment, people become a lot more mindful. They immediately, with this type of recording, many of them come to an awareness and a recognition that some of these things they're doing actually aren't helping. It's not really helping them to have repeating these thoughts and beliefs to themselves. And what we find, next slide, please, is that people will begin to change the thinking. And so, for example, when they start to think there's nothing I can do, they might say something like, I know this will be tough, you know, I've been through it before, but there are things I can do to manage and to get back to this. And we find when people do that, they're not unconcerned, they're concerned about the discomfort they're having, but they're more open to sticking with exercise and modifying their exercise program. So this simple experiment can result in changes in how people appraise and cope with pain. Another behavioral experiment and approach is to actually teach people certain pain coping skills that we know from research work, and then to have them apply them during and after exercise. Next slide, please. So for example, in many of our studies where we've done interventions integrating coping skills training into exercise, we use an experiential approach during which in a session we instruct them in a skill, say like relaxation or meditation, And then we practice that skill with them in the session and in the exercise session itself. And then we give them the challenge of doing little behavioral experiments to, while they're out exercising, integrate that skill into their exercise routine. We then work with them to evaluate and problem solve about how things went, and things that are working, build on those, and things that need refinement, we'll work with them to problem solve around that. And we work our way through this experiential learning through a variety of potentially helpful, can we go back to that slide, potentially helpful strategies such as activity pacing, exercising with another individual, setting goals that are meaningful to you, and so on and so forth. Next slide, please. So what are some of the issues that arise in this area? And since we only have 10 minutes to talk here, I can't focus on these issues in any detail, but I can pinpoint them and come back to them if there are questions. So one of the most interesting questions is, should you be teaching exercise and pain coping skills as separate interventions, or is it actually more effective to integrate them? And I would encourage the integration, but there are people on both sides of this issue, and I think it's a very interesting one. A second one is, how do we teach healthcare professionals, many of whom are not psychologists or behavioral science specialists, and maybe don't have the expertise in training in pain coping skills? How do we teach them to address pain coping efforts in their exercise work with patients? And that's another one we can come back to. An area that's been of great interest to us is the role that significant others, spouses, caregivers can play in integrating exercise into, coping skills training into exercise. Another area that I think is quite interesting are novel options for enhancing maintenance of pain coping efforts as part of exercise. Obviously, osteoarthritis is a chronic disease. You want people not only to maintain their exercise, but to maintain skills for managing pain that may come up during exercise or serve as an impediment to maintaining exercise. Next slide, please. I thought there were some additional implications, but we can stop there, and or maybe there are. You want to advance it one more? Maybe there's, yeah, move ahead. Move ahead, one more slide. Yeah, I think that the fifth point here is probably a new one, that applying these strategies during exercise, I should point out, we have evidence not only does this reduce pain, but it also can enhance psychological and physical functioning, which are important outcomes to patients. So I will stop there, and thank you for the help with the slides and for your attention.